Good evening, everyone. We're going to give just another moment for people to come into the space. Welcome this evening. We'll get started momentarily. Good evening and welcome to tonight's presentation, Beyond the BRCA Gene. Let's talk about genetics and cancer. Thank you for making your health a priority by spending an hour with us. I'm your host, Sarah Richardson, Oncology Marketing Specialist for Franciscan Health. I'm excited for our team to share some great information with you in this installment of our Cancer Education webinar series. This evening, with the help of one of our experts, we'll help you better understand the purpose of genetic counseling and who may benefit from testing, what cancer types can be hereditary and management recommendations, and the risks and benefits of genetic testing. Before we get started, I'd like to share a few housekeeping items. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. If you have questions to ask the presenter, please click the Q&A icon at the bottom of your screen. You can privately type your questions in this window. We'll be answering your questions at the end of the webinar. If you have a personal question that is specific to your own medical history, please note we may reply to you after the webinar by phone or email to protect your privacy. Our awesome administrator, Kirsten, is taking care of everything on the back end this evening. If you experience any technical issues, just type them into the chat window and we'll work to resolve them as quickly as possible. If you miss anything, no need to worry. We'll send the recording of tonight's presentation to you in a follow-up email. Now, let's get things started with a quick poll question to see why you decided to join us this evening. We'll have several poll questions throughout the webinar to keep you engaged. Let us know, what sparked your interest in attending this webinar? Your choices are A, cancer runs in my family and I'm curious if I should consider genetic counseling or testing. B, I personally have or had cancer and want to know if genetic counseling and testing is something I should consider. Or C, I'd simply like to know more about how genetics can play a role in certain cancers. Please take a moment and choose your answer. Great. It looks like we have participants in tonight's webinar who are here for many reasons. We're looking forward to sharing with you about cancer and genetics and helping you decide if cancer genetic counseling might be right for you or someone you care about. Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. I'm excited to introduce you to one of them who will be leading tonight's session. Malavika Praseed McGrail is the oncology and prenatal genetic counselor for Franciscan Health in South Suburban Chicago and Northwest Indiana. She serves clinics in Olympia Fields, Munster, Crown Point, and Michigan City. She is certified with the American Board of Genetic Counseling and licensed as a genetic counselor in Illinois and Indiana. She received her master's in genetic counseling at the Icahn School of Medicine at Mount Sinai in New York, as well as a Bachelor of Arts at the University of Notre Dame. She lives with her husband in Tinley Park, Illinois, and in her spare time is an avid reader, writer, and book reviewer for the Chicago Review of Books. Now, without further ado, please welcome cancer genetic counselor Malavika Praseed McGrail.
All right. Thank you, Sarah, for the wonderful introduction, and good evening, everyone. Thank you for joining us. So as Sarah mentioned, my name is Malavika Praseed McGrail, and I am the genetic counselor here at Franciscan, and one of many, but here in South suburban Chicago and Northwest Indiana. And so to begin, I just want to introduce what I do and what a genetic counselor is. And so genetic counselors are professionals who have specialized education in genetics and counseling to provide personalized help patients may need as they make decisions about their genetic health. And so for me specifically, as Sarah mentioned, I completed my training at the Icahn School of Medicine in Mount Sinai after finishing my Bachelor of Arts at Notre Dame, go Irish. I am licensed in Illinois and Indiana, and I have been with Franciscan since 2019, currently serving a variety of clinics, Munster, Olympia Fields, Crown Point, and then most recently, Michigan City. And so to set up essentially what a genetic counseling appointment is like, because I guarantee many of us may never have sat in on a genetics appointment before. So to start with, they start as one-on-one discussions between a professional like myself as well as the patient. We sit down and set an agenda as to what that patient is looking for and looking to learn in this particular appointment. We then take the medical and family history, and this diagram that you see here with the squares and the circles, this is what we call in genetics a pedigree, and this is our detailed family history across multiple generations that we take. And in this, we look for patterns in a family history that might indicate the suitability of genetics, as well as specific genetic conditions we may be suspicious of. We then take that knowledge and perform a formal risk assessment and discuss the feasibility and utility of genetic testing. The test itself is normally a blood or saliva sample, especially in the cancer realm, which is what we're going to be focusing on today. And then once those results are back, which normally take a couple of weeks, we then communicate those results. Results vary from positives, negatives to uncertain results, which is something I discuss in detail with a lot of my patients. And then lastly, we take that clinical information and we transfer it over to your management team, basically talking about what would change as far as screening recommendations, treatment recommendations, implications to family, really taking this genetic information and making it clinically usable. So that's the typical life cycle of a genetic counseling appointment. And so to start with a frequently asked question I often get, when you think about cancer as a whole and you think about where cancer comes from, in reality, only a small fraction of cancer is what we consider hereditary. The vast majority of cancer is what we refer to as sporadic or occurring at random. And this is where we think about environmental impacts or lifestyle choices. We know smoking can play a big role in cancer, for example, or just simply getting older. We know that cancer can affect older individuals more often than younger people. So there's a variety of different factors that contribute to sporadic cancer risk. And overwhelmingly, that's the majority of cases, less to do with family history or genetics. And then we have this middle ground, which I refer to as familial cancer, where we observe this strong family history of cancer, but we may not find a known genetic predisposition. And that can be a few different reasons. Maybe we haven't found the specific gene that's explaining this pattern. Maybe there's a shared environment in the family that's explaining that particular pattern, or maybe we just haven't discovered what's going on here yet, or there's a combination of factors. So there might still be additional screening that we recommend, even if there's no known gene. And then lastly, as I mentioned, only about 5 to 10% of cancer is strictly hereditary, meaning we can point this predisposition to a particular gene and consider that someone as being positive for that particular gene, so to speak. So definitely a minority of cases. And so thinking about hereditary cancer, now that we've established that this tends to be the minority of cases, we know that there are some common reasons for referral. Not everybody with cancer in their family may meet criteria for genetics. So normally we look for patterns such as people with cancer diagnosed at an especially young age, which we tend to quote as under the age of 50. We can see certain rarer cancers, such as ovarian or pancreatic cancer. Those are less common in the general population and may therefore have an increased risk of being hereditary. We can see individuals in a family who have had multiple types of cancer. Now, this isn't the same as one cancer that may have metastasized or spread to other body parts. Usually here we're referring to multiple primary sites of cancer. And then lastly, multiple generations affected with similar cancer types, such as say a sister, mother, and grandmother with breast cancer, for example. And then coming on to that, what types of cancer can be hereditary? Now, I've outlined a few of these types here. We're going to be mostly focusing on breast, ovarian, colon, pancreatic, and some prostate. But we also know that many different types of cancers can have hereditary predisposition. So I always say, when in doubt, speak to your physicians if they're suspicious of a hereditary predisposition. It definitely goes beyond what I've listed here, but for the purposes of brevity, we're going to be focusing on these more common conditions.
Thank you, Malavika. We've had some great information so far. But before we move on, let's test our audience's knowledge with another poll question. True or false, most cancers are hereditary? I'll give everyone a moment to go ahead and select your answer. All right, it looks like almost everybody got that right. Thank you for being engaged in our poll question. The answer is false. Only 5 to 10% of cancer is hereditary. Up to 70% of cancer is sporadic with no known genetic link. We'll turn it back now to Malavika for more on this important topic.
All right, so I know we've titled this presentation Beyond BRCA, but I always like to start with what we know and what most people are familiar with when it comes to genetics and cancer, and that focuses primarily on breast and ovarian cancer. So to start with breast cancer, we know that breast cancer is one of the most prevalent cancers in women. We currently estimate about 1 in 8 women are diagnosed with breast cancer in their lifetime. I always tell my patients, this is regardless of any kind of family history. If you have breasts, this is essentially your baseline risk. And that's why we encourage regular screening for our patients, whether or not they have a family history. So currently, the American Cancer Society, their general screening recommendations include between the ages of 40 to 44, an option for a yearly mammogram, between 45 to 54, recommending the yearly mammogram. And after 55, there's an option to bring that down to every 2 years. Now, this is one set of screening recommendations. There are other screening recommendations as well that are more firm on the yearly mammogram for a longer amount of time. And we also know that depending on factors like family history, the age to start a first mammogram can definitely be younger than age 40. So results may vary with these screenings, but these are the general guidelines. And if we compare breast cancer to ovarian cancer, we know ovarian cancer generally is much less prevalent than breast cancer. Current estimate is about 1.5%, less than 2%. And we also know that ovarian cancer is difficult to screen for. I always say that if you think about our screening for breast cancer, sometimes women can feel an abnormality in their breast, but this is much more difficult to do with the ovaries, and symptoms can sometimes seem a little nondescript. And so screening can be somewhat limited. There are providers that can perform a blood test called a CA-125, and there's sometimes a role for transvaginal ultrasound, but we do know in general this is a more difficult cancer to practice routine screening for. And so, as I mentioned, the most common genes related to breast and ovarian cancer are those BRCA genes. So beyond BRCA, but we're going to start with BRCA to sort of establish that. And the reason I start with these two genes, they're the most well-known. When genetic testing for cancer first started, these were the genes we learned about. And these were the genes for a long, long time were the only ones that were available to test. And there was good reason to test these genes because we know that they definitely increase the risk for breast, ovarian, and certain other cancers. And to illustrate this, I have a pedigree for a sample patient out here. Now, for those of you that have never looked at one of these diagrams before, our patient is delineated with the arrow down here. Her name is Sally. We know that Sally and other females are designated by circles, males are designated by squares. We see that Sally is diagnosed with breast cancer at age 42, definitely within that younger age that we previously talked about. We pursue testing for her and find she is positive for a BRCA1 mutation. And then taking a look at Sally's family history, we can definitely see where this mutation is coming from and how this is manifesting. So for one thing, we see Sally's sister, ovarian cancer at age 46. And we also see moving up a generation to Sally's parents. Sally's mother is unaffected, but Sally's father has prostate cancer diagnosed at the age of 70. And this is a common misconception we're always going with in genetics. You know, you don't inherit these breast cancer genes solely from female family members. Men do develop cancers related to these genes, and men and women are equally likely to pass these genes down. So in this case, the prostate cancer was likely BRCA1 linked, and the father was the source of this mutation. And then looking at his history, we see that Sally's aunt, the father's sister, bilateral breast cancer at 48, and then Sally's other aunt, who unfortunately passed, had both breast and ovarian cancer and also had a child with breast cancer. So we definitely see those patterns here. The BRCA, like other genes, are passed down in a dominant fashion, meaning there's a 50-50 chance if you have a mutation to pass that down to each child. And one thing we also note is that not everyone with BRCA mutations develops cancer. And to show you that, we see here there's another one of Sally's cousins who had bilateral breast cancer at 38, but her father is unaffected. And that doesn't mean he doesn't have the mutation. It likely came from him, since we know she's positive, but not everyone with these mutations does develop cancer. Almost none of the genes we'll be discussing today have a 100% risk for cancer. So this diagram is just meant to show us the different ways this can come about, but the importance in knowing about this mutation when it comes to tracking a family. And so because we know these risks are so increased, there are differences in how we manage these patients. And these guidelines are specific to BRCA1 and 2, but for a lot of the breast genes we'll be discussing, there are similar guidelines. So for instance, instead of just having that once-a-year mammogram at age 40, women who are BRCA positive are encouraged to start having breast MRIs at age 25, and then adding in mammograms around age 30. So once you get to be 30, the guideline is a mammogram and an MRI each every 6 months. So you're not waiting a full year to be screened again, and you're getting two different screening methodologies. And this is what's recommended for a lot of our high-risk patients, including our BRCA positive patients. But of course, that can be individualized depending on the family history. There are some options for medications like Tamoxifen, which is considered a chemopreventative medication. These medications can have other considerations and side effects, so it's always good to consult with providers, particularly an oncologist, if that's a medication that might be of use. And then one thing that is somewhat unique to the BRCA genes is there is the option of bilateral risk-reducing mastectomies for some of these women. So, for example, many people that have heard of the BRCA genes have heard of Angelina Jolie and how she removed her breasts to reduce her risk when she found out about her mutation. And that is an option for a lot of these patients. To give you a number, women with BRCA mutations have about a 55 to 85% chance of developing breast cancer in their lifetime. And so that surgical approach can definitely greatly reduce that risk. But we also know that that isn't necessarily right for everyone. That's a big surgery to undergo, and it's never required for any woman, whether or not she tests positive, to undergo that surgery. And so we always say that as long as you're having the high-risk screening that's recommended, you're considered well taken care of, but surgery does exist as an option. So that's the breast cancer angle of it. But with ovarian cancer, our management is a little bit different. So as we've established, it's a difficult cancer to screen for, and there's not a lot of options in terms of those screening recommendations. We can consider the transvaginal ultrasound and CA-125s, but in reality, for most of our BRCA positive patients, we are broadly recommending BSO, or bilateral salpingo oophorectomy, which is removing your fallopian tubes and ovaries, either when a woman is done having children or between the ages of typically 35 to 45. Again, that can be individualized. We always state that we usually do not like to remove the ovaries prior to that age range, because even if we don't plan on having children, we as women often do need those hormones as long as possible for our heart health, bone health, and other functions. But overwhelmingly, the guidelines have shown us that the risk of ovarian cancer, instead of that 1.5%, goes up between 15 to 45% with these genes. And because we know ovarian cancer can be aggressive, that surgical preventative option is really our gold standard here. And so now getting to why I titled this presentation Beyond BRCA, and that's because in the last, I would say 5 or so years, we have made great strides in terms of understanding other genetic predispositions to particularly breast cancer, but as we'll go into other cancer types as well. So this pie chart is very simplified, but it essentially shows us about half of all hereditary breast cancer has to do with one of the 2 BRCA genes, but that leaves another 50 or so percent that have to do with a variety of other genes. And some of them are listed out right here in the bubble. And you may or may not have heard of some of these genes before, but we as genetic counselors, we certainly have. And we know that the guidelines for each and every one of these genes continues to change and grow. Each of these comes with its own medical management guidelines. We're constantly doing research in some of these genes. In fact, some of these genes that are listed now have since sort of fallen out of favor in terms of their increase in risk. So this is something we're constantly evaluating and have established guidelines for the vast majority of these genes. And so now transitioning a little over to what I feel is an underrated topic of discussion, especially when we talk about genetics and cancer, and that is colon cancer. We know that colon cancer is becoming increasingly more prevalent, especially at younger ages. Currently, we say about 4 to 5% for an overall prevalence in the population. And actually, because we're noticing more and more younger diagnoses, the American Cancer Society recently updated their recommendations to say that first baseline colonoscopy should be at age 45 rather than age 50, as was previously recommended. And so that's the ACS guideline, but of course, if there's a family history involved, that can definitely alter some of those guidelines. And so what type of screening do we undergo? Well, there are 2 types of screening that are generally offered: colonoscopy as well as stool-based tests like Cologuard, for example. We know that colonoscopies are still considered the gold standard, especially if you're high risk, especially if you have a family history, especially if you're establishing a baseline. Colonoscopy is still what's broadly recommended by most GI providers, although stool-based tests can be an option for some lower risk patients, but we always say defer that judgment to your managing physicians. And then coming back to genetics a little bit, we know that genetic syndromes related to colon cancer, you can separate those broadly into what we call polyposis and non-polyposis conditions. Polyposis simply means we see polyps, and in these cases, lots and lots of polyps, sometimes dozens, sometimes hundreds of polyps. The non-polyposis conditions do have polyps associated, but usually it's a much smaller number, maybe a couple of them, maybe only 1 polyp, but typically not the widespread nature of polyps that we see with the polyposis conditions. And due to time, we'll be mostly focusing on the non-polyposis conditions here, since that tends to be most common. And so one example of a common non-polyposis colorectal cancer syndrome is Lynch syndrome. And for those of you who may or may not have heard of it, Lynch is named for the doctor who discovered said syndrome. We estimate its prevalence of about 1/440, which is actually very similar to BRCA mutations in terms of overall prevalence, but definitely less talked about and less heard of. We know there are 5 genes related to Lynch syndrome, and you're considered to have Lynch syndrome if you have a mutation in any one of these 5 genes. It is also a dominant condition, meaning 50-50 chance of passing it down, same as those BRCA genes. Well, one thing unique to Lynch syndrome is there are a multitude of cancers that can be linked, not just colorectal. We see an increased risk in uterine cancer, ovarian cancer, stomach cancer, and actually several others, as we'll get into. And so to give you another one of my pedigrees here to illustrate how Lynch syndrome can manifest in a family. So you can follow our patient here, denoted with her name, Jacqueline. Jacqueline is 52, diagnosed with uterine cancer. And looking at Jacqueline's family, we do see the hallmarks of Lynch syndrome present here. So moving up a generation to Jacqueline's father, 75 years old, but diagnosed with colon cancer under the age of 50, age 49. Jacqueline's uncle, colorectal cancer at 61 and who passed away of the condition. And then moving up to Jacqueline's grandmother, who actually had 2 diagnoses, colorectal and uterine cancer in her lifetime. And then moving down a couple of generations, we see that Jacqueline's unaffected brother has had a child who passed, unfortunately, very young, age 26, of colorectal cancer. So again, we see, like BRCA, not everyone with the gene mutation develops cancer, but can still pass that down, and that can still result in cancer. So this is an example of what a family with Lynch syndrome might look like, but not all families have quite this, we call it penetrance, the number of people that have developed cancer. Some families look quite different. This is just one example.
Thank you, Malavika. It's very interesting to see that case example. We are learning a lot this evening, and remember, please type your questions for Malavika in the Q&A window so she can get to as many of those as possible after the presentation. Let's answer one more audience poll question this evening. True or false? You should have your baseline colonoscopy starting at age 45 only if colon cancer runs in your family. Take a moment and go ahead and answer true or false to that question. All right, the answer to our final poll question is false. The American Cancer Society recommends a screening colonoscopy beginning at age 45, regardless of your family history. If you have a family history of colon cancer, you should receive your first colonoscopy 10 years prior to the age your relative was diagnosed. This important screening may find polyps and allow your doctor to remove them before they ever become cancerous. So be sure to schedule your colonoscopy if you're due. Thanks so much for taking part in our poll questions this evening. Now Malavika will share with you some information on lifetime cancer risks.
So I'm not going to go through every single box in this very complicated table, but this is just meant to illustrate that, like the BRCA genes, there are a significant amount of cancer risks with Lynch syndrome as well. So I mentioned colon cancer, those risks can move upwards of 50% depending on the gene. Similar risks for endometrial cancer. We typically don't see breast cancer and prostate cancer being increased to the level that we see of the other cancers. I included them here to sort of show as a comparison that they're more similar to population risk. But we can see ovarian, gastric, and pancreatic cancer increase to some degree, and that does prompt changes in screening, which we'll get to in just a moment. And so the moment is here. So essentially with Lynch syndrome, we're generally recommending colonoscopies starting as early as the early to mid 20s if it's diagnosed that young, or 2 to 5 years prior to the earliest colon cancer if it's before age 25. And then we're repeating these colonoscopies every 1 to 2 years. So it's not the 5 to 10 years we see for our average risk patients. This is much more frequently than that. For stomach cancer risks, we can consider upper endoscopies with your colonoscopies beginning around age 40. And then for uterine and ovarian cancer, again, uterine cancer as well, it can be harder to screen for. There is the role of biopsies as a screening option, but some women do pursue hysterectomies along with the ovary removal if they've completed childbearing and to reduce their risk as much as possible. So these are some examples of screening recommendations, but I'll also provide the caveat, this is one particular colorectal syndrome. There are others. They all have their own management guidelines, and a genetic counselor would be able to go through those with you in detail. And so now moving on to pancreatic cancer, which is definitely an emerging field in cancer study as well as in genetics. We say that the average risk for pancreatic cancer is approximately 1 in 64. And we know that pancreatic cancer can be quite an aggressive diagnosis in a lot of people. And we know that we're still learning a lot about how to catch pancreatic cancer early, how to treat it, so on and so forth. Screening when you're unaffected currently is largely occurring at research centers, largely research-based and highly dependent on family history, genetics, and other factors. The screening is usually imaging, MRIs and MRCPs of the pancreas, endoscopic ultrasounds, things like that. But again, these are largely performed at research centers and usually only for patients with significant family history or particular genetic mutations. Those individuals are then instructed to speak to those screening providers about how and when to start that process. But again, pancreatic cancer, an example of we made strides so far in identifying sources of our understanding, and I'm optimistic for the future that the more we'll learn, the better outcomes will be. And so now getting to the nuts and bolts of genetic counseling and genetic testing. So some of these are common patient concerns that I encounter. The first I get, and this is totally understandable, especially in our day and age, what is this going to cost me? And so financially, in terms of the visit, the cost of the appointment is generally covered by most insurance companies, especially if you have that family history. Visits are often pre-authorized ahead of time, and you're informed about that before you schedule. And for testing, coverage of testing for patients who meet criteria is typically very good. Insurance companies have really tuned into genetic testing, and they know that down the road, paying for preventative testing, preventative screening can definitely make outcomes better in the long term, which helps their bottom line as well as helping the patient. And so that important point, meeting criteria, that's important. And that's something a genetic counselor would be able to help you navigate. Is your family history enough that genetic testing would likely be covered for you? A lot of that remains to be seen from the actual appointment, and that's something that we can certainly clarify. Another question, more psychological in nature, why would I want to know this information? I have some patients or prospective patients who think genetic testing feels like opening Pandora's box, anticipating something they may or may not want to know. And the first thing I say is that is a totally valid feeling, and genetic testing isn't right for everyone. For some people, it may or may not be information that they're ready for or want to know at this time. But to sort of take a devil's advocate approach, medical management recommendations would be altered and aimed at early detection and prevention if we did find out about this mutation. I always say the mutation has always been there if it's there. And now that we know about it, we can take steps to prevent against potential cancer. Another thing, as I mentioned earlier, having a mutation is not a cancer diagnosis. It's unable to tell if there's cancer in your body, and very few, almost none of these genes have a 100% risk for cancer. They are merely increased, albeit to high levels in many cases, but they are risks that we can then mitigate. And then on the flip side, especially if there's been a mutation in your family, testing may indicate that you are not at risk or not at a significantly increased risk, and that might alleviate some anxiety. So we see a lot of potential outcomes to genetic testing. I would say for patients who are on the fence, having a genetic counseling appointment is never signing away and mandating that you have to have testing. Sometimes it's just helpful to sit down and talk to someone about your concerns and learn as much about it as you can. And then lastly, I have patients who are concerned if testing positive will impact their health insurance coverage or their employment and things like that. And there is a law, a congressional law, the Genetic Information Non-Discrimination Act, or GINA as we call it. This was passed in 2008. And the goal of this was to prevent discrimination by employers and health insurance companies. So that applies nationwide. There are some exceptions, like if you work for the military or the federal government, there are some exceptions there, but otherwise nationwide. But what this law does not apply to is life insurance, long-term care, or disability. So the conversation about establishing a life insurance policy, when to do that, definitely an important conversation to have with a genetic counselor before having genetic testing. So to wrap all of this up, essentially genetic testing for hereditary cancer conditions can allow for preventative screening and medical management, and can help inform family members about possible risk. And honestly, that last one is a big one. I have a lot of patients who come in and say, I'm doing this for my kids. And that's a totally valid reason to think about this in terms whether or not you've had cancer before and you just want to spare your kids maybe some of the anguish of being treated. There's a lot of different motivations for genetic testing, and doing it for families definitely a big one. Only about 5 to 10% of cancers are considered hereditary. So vast majority of my patients do end up testing negative, which can be some relief. And then reasons for referral over to genetics include cancer at a young age, certain rare cancers, multiple generations affected, or multiple types of cancer in a single individual. And then I have patients who always come in and say, what do I need to prepare for a genetics appointment? Do I need to do anything? And I would say, if you do one thing before you walk into my office, talk to your family about the family history, see what you can learn about that aunt or that uncle or that cousin or that grandmother, as much as you're able to gather. Now, I understand not everyone's family structure and family situation is the same, and there are always limitations to what we're able to know in family history. But honestly, whether or not you pursue genetic testing, knowing about your family history can be really helpful in terms of managing your own health. And I want to thank you all for joining me today. And now I am open to questions. And as a reminder, if they are personal in nature, feel free to contact us. I have my office number down here on the slide. And so if you need to reach me directly, you can certainly do that. But I am open to questions at this time.
Thank you, Malavika. We hope our audience has learned some new and helpful information. We know it is a lot to unpack, and we've received some really good questions. So let's move into that question and answer time. Our first question from one of our audience members, this is an interesting one. How reliable is the testing from home kits such as 23andMe?
So that's a great question, and it's one I get all the time. And I always say that kits such as 23andMe, they advertise that they're now looking at hereditary cancer genes. And, I always say take those things with a grain of salt. I can quote you studies and risk numbers, but basically the bottom line is they are not looking thoroughly at every gene that we would be considering in genetic testing. There is an increased risk of false positives. And even 23andMe on their kits, they stated that anything comes back concerning, you have to get it confirmed clinically by a reputable clinical genetic testing lab. So I would say that if you do pursue 23andMe or have a 23andMe result in mind, definitely discuss the results with your provider, see if further follow-up is needed. And if you're thinking about doing 23andMe, keep in mind it's mostly geared towards entertainment, and take the clinical information with a grain of salt.
Okay, wonderful. So we have another question. We have someone on our list here who is asking about what can they do if they don't have detailed family history because they're adopted, but they're curious about their genetic risk for cancer.
It's a great question. So I've seen many patients who are adopted. When you're adopted and trying to figure out what you're at risk for, like I said, there are limits to what we all know about our family history. For our adopted patients, it's definitely possible to pursue genetic testing. Now, the caveat is, are you more or less likely to be covered? Insurance companies may be a little stiff to cover someone when they don't have a known family history. But one of the things that has evolved about genetic testing in recent years is there are self-pay options. Testing has become more affordable over the years. So I would state that it's definitely possible to pursue genetic testing, definitely worth coming in for a counseling appointment if you are concerned. And we would talk through those caveats at the session.
Okay, thank you. The next question we have is AML blood cancer, one that you see that is inherited.
So yes, so I'm glad you bring up AML and other hematological cancer. So that's another area where we're learning a lot about genetic links. So I admit that I am not an expert in hematological malignancies. They're an area that we're constantly learning more about. There are certain hematological malignancies that are more likely to be hereditary than others. Typically, we are looking to see if there are particularly high-risk markers. Is there a significant family history? Those are things that might point us in the direction of something potentially hereditary. The vast majority of heme conditions, leukemias, lymphomas, do tend to be more on the sporadic side. But again, I would say defer to your physicians and potentially look into having a genetics appointment to take your family history in more detail.
All right, the next question we have, can prostate cancer and breast cancer be related? For example, one male sibling with prostate cancer and two sisters have breast cancer.
Absolutely. I'm glad they bring that this person brings this up. So the BRCA genes are a great example. The main cancer risk we see for men with the BRCA genes is that increased risk in prostate cancer. So that's approximately doubled from the average risk of about 12 to 15% in men. So that is doubled for BRCA positive carriers. We also know that those cancers can be higher grade or more aggressive or younger onset ages. So usually, yes, when we do see a sign where a male sibling has had prostate, two family members with breast, my red flag would be going up and thinking, has this person had a genetics evaluation? If not, definitely worth considering.
Okay, thank you. Another question we have is, can all my health concerns be addressed in a single visit, or will I need to be seen by another genetic counselor in a different specialty, perhaps if they have a concern about heart or something along those lines?
Great question. So I often, I get the question, do you do it all when it comes to genetics? And now I work in two specialties. I work in maternal fetal medicine as well as in oncology. But in reality, genetics is as multifaceted and as distinct as, say, your doctors that each have different organs that they specialize in. So if you came into my hereditary cancer session and showed me a very significant history of cardiovascular disease, for example, I might say, okay, there might be a role here for cardiovascular genetic testing, but I would not be the right provider for that. But I would be able to point you in the right direction towards finding those providers. Genetics is a pretty small world. A lot of us do tend to know each other, and we know our patients can achieve the right type of care that they need. So long story short, one genetics visit doesn't address all possible genetic concerns, but we usually do have ways to point you where you need to go.
Okay, wonderful. Thank you so much. We have another question here. If someone has the BRCA gene, does that mean their daughter and granddaughter will automatically have that gene as well?
Good question. So the BRCA genes, as well as almost all of the other hereditary cancer genes, are dominant, meaning that each child by someone who has a BRCA mutation has a 50-50 chance of inheriting that gene. So a coin flip, if you think about it. And so as a result, we would be recommending testing with each generation. So for instance, if mom has a BRCA mutation, we'd then be thinking about testing daughter. As long as daughter is over the age of 18, we typically do not test children. We would then want daughter to be tested. And then if daughter is positive, she would potentially have a 50-50 chance of passing that down to each of her children. And this is sons as well as daughters. So important thing, if you are positive, your son should also be tested as well as your daughters.
Okay, we have another question here. If I have genetic testing now, does that ever need repeated in the future, or is it kind of a one-time process?
These questions are great. I'm so happy to see these. So yes and no. So genetic testing typically is a one-time thing, especially when we do what we do now, which is called multi-gene panel testing. When we look at a large variety of different genes and assess them, the spelling of our genes, that typically does not change over time. What could change in the future is our interpretation of some of these genes, and what also might change is discovery of new genes that might be linked to an increased risk. If that's the case, there might be a role for updated testing in the future. An example I give is maybe about 10 years ago, women with breast cancer were being offered BRCA testing, and they might be BRCA negative and think, okay, I'm in the clear as far as genetic mutations. But now we're recontacting a lot of those patients to say, hey, we know there are many more genes out there now that we want to consider. We'd like to bring you back in to talk about some of that updated testing and see if there's something else that could be going on in your family explaining your diagnosis. So we are still learning more about genes all the time, but for those given genes, typically that testing does not need to be repeated unless there's more being added.
It sounds like such an interesting field because it's just constantly evolving over time. So um, we have a question here. How accurate is the genetic test? And is it possible for my test results to be uncertain?
Great questions. That's two different questions here. So in terms of accuracy, clinical genetic testing is highly accurate. We always say there is a small chance with any kind of lab result for an inaccuracy, but we only order testing through validated laboratories that we trust widely. And a lot of these labs, they do publish their data broadly. You are able to compare a variant with how other labs are reporting it as well. And we look for that concurrence when we're reporting anything. So long story short, highly accurate, more accurate than, say, your direct-to-consumer testing, as we discussed earlier. We're definitely relying on clinically validated sources. But in terms of uncertainty, so that's very different. So uncertain results in genetic testing are actually really common. Basically, how I describe them is, we all have these different variations in our genes, and sometimes an uncertain result, that's just a variation in a spelling we happen to get, and we just don't know what the significance is of it yet. We don't know if that changes enough to completely disrupt the gene and make us more vulnerable to cancer, or if it's just a normal spelling that just makes us all different from each other. So those are the uncertain results. Vast majority of them, I say something like innocent till proven guilty, because we all have these variations. The vast majority of them are generally downgraded to negatives, but we do keep an eye on those and see if any research changes our understanding of them. The spelling itself does not change. What changes is our understanding of them. So we keep our patients up to date about those.
Okay, thank you, Malavika. We have another question this evening. If I've already been diagnosed with breast cancer, can genetic testing help predict whether my breast cancer will come back?
That's a complex one for sure. So there are certain genes where if you test positive, there may be an increased risk for a second breast cancer down the road. You might think of it as a contralateral breast cancer, for example. So say if you had right breast cancer, might be an increased risk for left breast cancer or a different cancer. What genetic testing is a much harder time predicting is whether the same cancer will come back. And there are normally other tests that oncology can order for those. Those are a little outside of our scope of our discussion, but there is testing they can sometimes do on tumors or on liquid sample, looking more for certain markers that might indicate an increased risk of recurrence. That's an emerging field for sure. So the answer is sort of yes and no. Certain genes linked to second cancers down the road, but wouldn't really be able to predict rate of recurrence.
Okay, I gotcha. We have a question this evening from someone. They had a relative who just passed away very suddenly from pancreatic cancer. We're definitely sorry to hear about that. It's a very difficult cancer to diagnose. and now this person is concerned. Should they get genetic counseling to see their risk for also developing pancreatic cancer, or what would be their next steps, do you think?
Absolutely. So I would say the next step, speak to your physician about this family member. And first of all, I want to reiterate, I'm so sorry for your loss as well. Pancreatic cancer is truly devastating, and part of the devastating factor of it is how hard it is to find. And so definitely do be proactive. Speak to your physician about this family history. The current guidelines state that anyone with a first degree family member with pancreatic cancer, first degree usually meaning a sibling, a parent, a child, so to speak, those family members automatically qualify for genetic testing or genetic counseling, even without any other family history of cancer. And if there are other cancers in the family, we can still consider testing, even if it's a more distant relative. So we're rapidly noticing that pancreatic cancer is has strong hereditary links, and there can be certain genes that we can be on the lookout for and may be able to instate some screening recommendations. So definitely talk to your doctor first. Explain the level of relationship between yourself and this family member, and they can assess and see if genetic testing would be right for you.
Okay, we have another person who's with us this evening. They are positive for ovarian cancer and has the BRCA HRD negative. They have 3 family members who have had prostate cancer and another family member who has had colon cancer. They're wanting to know, if the cancer is non-genetic, what accounts for all of the cancer in their family?
Absolutely. And so I'd say this with a grain of salt. For the person who submitted this question, I haven't reviewed your test results in detail. But if what I'm taking at face value that your genetic testing has come back negative, we know that even with a significant family history of cancer, we have not found every genetic predisposition that explains these patterns. There's still large gaps in what we know. And that's why I generally default to that pie chart that I showed, that 20 to 25% of cancer is simply familial, meaning we have not found a specific genetic link that's explaining some of these inherited factors. Now, is it possible that maybe there are genes that weren't included in your testing that might account for this history? Possibly. It might also be that we have not found said gene yet. There might be a shared environmental factor. There's a lot of different possibilities that this could be. I would say that if you are concerned, bring it up with your physician. And if you haven't had genetic counseling, I'd recommend it.
Okay, thank you. We have another question this evening regarding insurance. This one is specific to Medicare. Does Medicare cover genetic testing?
Great question. So Medicare currently, their guidelines state that anyone who has had cancer is covered for genetic testing. That is a broad Medicare guideline. For our Medicare patients who have not had cancer, a lot of the labs do have options to cover those patients, even if they don't meet Medicare strict guidelines. I would say a vast majority of my patients I see do tend to be Medicare covered, whether they're affected or not. That's something we definitely be able to speak in more detail at a session, but I would say just based on that coverage alone, that shouldn't dissuade you from genetic counseling.
Okay, we have another question. Can I make an appointment with you or a genetic counselor without a physician referral?
Yes, so here at Franciscan, absolutely. Your mileage may vary at certain other sites, but we do take self-referrals, sometimes especially if a family member is tested positive and they're like, you have X amount of time to be tested. It may be difficult to just go get a physician referral. So we always provide our direct contact numbers. We do take self-referrals. We do authorize your visit and see if you're covered by insurance. I provide the caveat that if you have an HMO plan, they usually do require a physician referral to see anybody. But for most of our patients, yes, you can be seen with a self-referral.
Wonderful. And we will send out some information to everyone after the webinar is over. You'll receive a flyer that has that information to contact Malavika, or if you are around our Indianapolis or Southern locations, we have some other genetic counselors here as well. All right, next question. Cancer in multiple generations is significant, but what about parents who both had the same type of cancer? They didn't live together or share the same lifestyle or environment.
So from what I'm understanding, it sounds like mom and dad both had similar types of cancer, and now we're concerned about it. Now offspring are thinking about their potential risk. So there's a lot of caveats there. I mean, obviously, we're assuming your parents are not related in any capacity, didn't grow up together. Some of those other factors can't be accounted for. I would say, depending on the specific type of cancer, some of them can be pretty common in the population. So for instance, 2 parents with colon cancer that can just be a coincidence. It could increase risk. It may just still prompt additional screening, especially if they were young. But if they were younger, if it's a rarer form of cancer, if we do see other family members with cancer, we might be thinking about a genetic predisposition, but just solely based on two parents with similar types of cancer, we wouldn't be as suspicious as if they were on the same side of the family.
Got it. Well, we have a couple more questions here, and then we're going to wrap up for this evening. What are the limitations of genetic testing for cancer?
Oh, it's a good broad question. So one of the limitations is that it cannot tell us about recurrence. It cannot tell us about severity. If you were to develop cancer, we can quote studies, we can quote trends, but it can't tell us about anything individual. That's kind of a case with genetic testing overall. There can be limits to the number of genes that we know about. That's, as I've mentioned before, that's always changing. There are significant limitations. It may not be able to predict every type of cancer that's running in a family. Some may still run unaccounted for, and we're more looking at screening as a method of understanding risk than any genetic factor. So, and the big one is, if you test negative, that doesn't necessarily mean you won't develop those cancers. As I mentioned, only about 5 to 10% of cancer is hereditary. So we always say, even if you test negative for every gene we have to offer, still keep up with your recommended screening. We know that cancer can arise for so many different reasons, only a fraction of which that we know about. And so still keep up with your regular management, especially if you still have that family history. So I would say those are some of the major limitations of genetic testing.
Okay, our next question is someone who says their father had lung cancer and mother had breast and lung cancer. A half sister had breast and liver cancer. Should they be tested? Sounds like they're a good candidate for some of those early screenings, mammograms, and things like that.
Right, absolutely. So with lung cancers, most forms of lung cancer are largely environmental. We think about smoking or other toxins in the environment. Most of them do not have a known hereditary predisposition. Breast cancer certainly can. Liver cancer also tends to follow into more of that sporadic category. So again, I'd have to take your whole history, really sit down with you, see if you meet criteria. So I'll defer that to, if you do have concerns, talk to your physician and see about an appointment.
Okay, we have a question. Can you talk a little bit about environmental factors for developing cancer rather than just hereditary?
Yeah, I can speak to that a little bit. So obviously a lot of that is a little outside of my scope. Someone in the oncology or even general practitioning field might be able to speak more to it, but environments is a very broad term. So we think about things like growing up near certain factories. For example, I see a lot of patients out of Northwest Indiana who told me they grew up near certain factories and they know that certain towns might just have more pollutants and things like that. So we know those can definitely be a factor. We think about workplace exposures like radiation encountered regularly. We may think about smoking is a big one, or tobacco use in general. We think about certain diet or lifestyle factors. Again, I'm not an expert in any of these fields, so to speak, but we also know there are environmental factors that we can't even really account for in a concrete way. We just know that they're likely not hereditary in nature, but they are working with our genes in some capacity to increase our risk for cancer.
Okay, thank you. We have one more question this evening. This is kind of a specific one as well. A person whose sister had breast cancer and brother has multiple myeloma, do they have a chance of getting any kind of cancer?
So obviously, chance of getting any kind of cancer, big question. So there's definitely an increase in risk if you have a family history. But actually, with this particular question, I will sort of turn it on its head. If you have a family history of cancer and you know and are close to certain family members that have been diagnosed and they are still with us, I would say your best bet is to see if those family members that have had cancer have had genetic testing. And the reason I state that is if the sister, for example, who has had breast cancer, has had genetic testing, comprehensive testing, and is negative, that would greatly lower your risk of having a hereditary predisposition to breast cancer. We always say that our patients that have been affected are our best candidates for testing. Now, it's not always possible to know that information or for those family members to be tested, especially if they're no longer with us. But I would say that that's where it really becomes important to communicate with family whenever possible and see if any genetic testing has been pursued, because that can definitely guide us in the right direction.
All right, wonderful. Well, thank you so much to our expert genetic counselor, Malavika, for sharing helpful information with us this evening. I think we're going to wrap up here. If we didn't get to your question tonight, we'll do our best to contact you by the phone number or email address you provided at registration. If you feel after tonight's session you would benefit from a cancer genetic counseling session, please contact your primary care provider. We'll also email you our genetic counseling flyer, which includes contact information for our genetic counselors to make an appointment. Finally, thanks to all of you for attending tonight's webinar, Beyond the BRCA Gene. Let's talk about genetics and cancer. We understand your time is valuable, so we thank you for prioritizing your health to spend some time with us this evening. Once again, we'll send you an email with the recording of this session. Feel free to watch it again and share with others who might find it helpful. You'll also receive a brief survey about this webinar and its content. Your feedback is truly important to us and will help make future seminars even better, so please take a few moments to fill out the survey. On behalf of everyone at Franciscan Health, thank you for being with us and have a blessed evening.